Hello, and welcome to Out of Our Shell, the podcast with your two hosts, Liv and Amber. We're the podcast that's going to be bringing you some amazing guests, some great topics that matter to our community, and we're going to try to have a little bit of fun along the way. And speaking of amazing guests, this week we have Dr. Jailyn Avila with us. So, Amber, since you invited
Mhm.
Dr. Avila on the pod, why don't you
Mhm.
tell us a little bit more about our guests before we bring them on?
Yeah, absolutely. So like a lot of the folks that initially were in the Out of Our Shell community before the podcast, we all kind of met each other through the watch band that I had been selling for the last 2.5 years prior to us coming together and doing this. In fact, that's how our relationship started,
Yeah.
was through that. And anybody that's ordered a watch band from me knows that I try to engage with my customers, and I really try to, draw them into the community that I've helped to kind of like cultivate in my tiny little space of the internet, because these connections have grown so strong. In fact, we all kind of got together over the summer at this little kind of party that we put together for Sabrina's birthday, my wife's
Mhm.
birthday, out in West Hollywood. And it was
Yeah.
so great because I think, gosh, it was the most gender diverse party I think I've ever been at in
Oh
my
gosh.
entire life.
Hmm.
And one of the best feelings is like going to that party and just kind of being around everybody that was, exactly like you. You forgot for a
Yeah.
moment that you were trans, and it was
Yeah.
such a fun night that night. And obviously we all hit it off like really, really wonderfully,
Hmm.
just like we did online. And so when it came time for us to like kind of like do this podcast, I know that we talked about like our mission is really to just kind of like create a pod where we're bringing different perspectives in our community. We're talking about the challenges, we're talking about the triumphs, and we're also looking at
Hmm.
things that matter to us most, like our
Absolutely.
medical issues, how we take care of our body, what we put into
Yeah.
our body, and what helps us transition. And so when we got to a point where it was like, okay, we want to have a medical expert on that could really kind of break this down, that is
Hmm.
amazing at public speaking, that does a fantastic job of kind of taking the complex and putting it into something that like the layperson can understand.
Yeah.
For me, there was no other person really to think of. I mean, she's amazing, and I think that we're
Hmm.
going to hear that in the pod today and everything. So I'm just really looking
Absolutely.
forward to everything. I've got a whole list of questions for her, so hopefully we have enough time in the hour and
Yeah.
everything.
Yeah.
But with that being said, though, I do want to say this very clearly. This is not a medical geared podcast at all. This is just for informational and entertainment purposes
Hmm.
only. By
Yeah.
no means, please construe our podcast as any type of medical advice whatsoever. You should absolutely consult your primary care physician or a medical provider that you absolutely trust and have contracted to help you out.
Hmm.
So, with that,
Yeah.
I think,
Yeah. So,
yeah.
we try to keep our shows within an hour, and I think we're gonna have a lot of content to cover.
Yeah.
So, let's go ahead and get
So I should
started. Are you
probably
ready?
stop talking. Yeah, I'm definitely ready.
Yeah.
Let's do this.
All right. We'll be right back, everyone.
Hi, it's Amber, and joining me today, I have Crystal from the Ascension Apothecary. Crystal, I just wanted to thank you so much for your generous donation for our Trans Day of Visibility event here in Ventura. It was a huge success. Thank you so much.
That's incredible. I'm really happy to be a part of it. I support you 100%. So whatever you want to do, girl, I'm there for you.
Oh my god, I love you so much. So, Mercury is in retrograde, huh?
Hmm.
Yeah.
Yeah,
So,
girl.
what does that mean for the expressive types, the ones that rely on communication and everything? Like, what can you tell us a little bit about that?
Well, I can tell you that well, starting anything during retrograde is a little risky, right? So
Mm-hmm.
um we typically want to look at retrograde not as a bad thing, but as a way to slow down, stop and smell the roses, look at things from a fresh perspective, right? And so but like who's ever had any fun playing it safe, right? So a lot of people do still go on with their daily lives, or they try new
Mm-hmm.
things, or they start new podcasts
Right?
during retrograde. And it really is a wonderful time for you to stop and reflect and look at things differently than the way that you regularly do. Um, because a lot of times we live life on the go, 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 especially, depending on your signs, right? If you're a fire sign, forget about it. Right. And so the Aries is all about getting things done. So retrograde during this time was really rough because we had the eclipse that brought in a lot of fresh starts. And so when you tell a fire sign or any sign, right, you can have fire in any of your placements. It doesn't have to be your sun. When you say go, like Aries did with the eclipse, and then you have retrograde saying, no, hold up, wait a minute, wait. You're not ready yet. It can be a little frustrating. So I will tell you that at this time, when it comes to people who are struggling with communication or expressing themselves because of retrograde, I will tell you the only reason why is because we need instant gratification, right? I need closure. I need a solution. I need understanding. And it's really just a matter of being heard. I just want to be heard. I don't necessarily need a answer from you, partner, coworker, friend. I just need to be heard. And so I think if you can look at it as, you know what, first off, I got something to say. We don't have to have an answer to it at this time, but I need to get it off my chest. It will help the flow of things through retrograde. But we're done with the eye of the storm. So at this time, it should be getting better, definitely.
Almost done with it. That's right. So, Crystal, you're obviously a little bit of an expert in this field. You have the apothecary. Tell us a little bit about it.
So Ascension Apothecary, Ascension is my last name, right? So Ascension Apothecary is really just a modern day approach to finding healing. This is nothing different than what our ancestors did, for hundreds of years. But it's more of a modern approach. I like to put a little spin on it. The thing is that the clients that come to me really are just looking for clarity. They're looking for insight and then some type of solution. And if we can figure out a holistic way, right? Because everything to help us is really doesn't cost anything. It shouldn't cost much, right? A lot of it is inside of us. Body movement is really important to healing. And that doesn't cost anything, right? To just shake things off. So I like to work with my clients and help them find a holistic but modern day approach to healing.
That's awesome. And do you have any special deals that you might be able to offer some of our listeners or viewers?
Well, technically right now I'm on a hiatus because I just had a baby.
Yes, you did. Congratulations.
I know, thank you. I love her so much. She completes me. She really does.
She's so beautiful.
I don't have anything open right now. Like I'm not taking any new clients, but I do have a special. If you, so like the first 5, that DM me at Ascension Apothecary 661 on Instagram, let me know that you heard me through this podcast. I will mail you a evil eye protection bracelet. It'll be cleansed and charged using my own rituals that I've learned, again, through years of just practicing with people who have been doing this forever. And then I'll mail it to you.
Oh, that's so sweet, Crystal. Oh my gosh, thank you so much. And I just want to remind my listeners, Crystal's always been a huge supporter of our community. She's very involved in her own community and is such a fierce advocate. And so anytime that, I want to work with folks, I'm always looking for folks that are working with our community. So I highly, highly encourage you to check out Ascension Apothecary 661. Crystal, thank you so much for joining us today. I really appreciate it.
Thank you, Amber, for having me. Love you so much. Bye, everyone.
Bye. Let's get back to the pod. Hi, and welcome back to Out of Our Shell, the podcast. Joining us today, we have Dr. Jailyn Avila, who is an emergency room doctor down in Southern California. Dr. Avila, will you tell us a little bit about yourself?
Absolutely. Thanks so much for having me on. I noticed that we
are
absolutely
all 3 of us. I think yes, absolutely.
Thank you. Yeah, really appreciate the watch band. I'm on my second one because I literally
That's
only
so
use this
awesome.
watch band. It's high quality. It's cute. It has trans colors in it. It's everything.
No, we're supposed to be plugging you.
That's how we met.
We're supposed to be plugging you.
No, I know, but I really like my watch band. I'm not plugging anything here. I'm just saying what I like, and I like this watch band. But if you want to purchase it, it's the Out of Your Shell
Out of Our
Instagram.
Shell. Yes, Out of Our Shell at
Instagram.
.etsy.com. Yep, you could go there.
.etsy.com.
Yep.
Yes, please.
Or right onto Instagram. Wow, thank you. I'm totally embarrassed. You totally threw me off. That wasn't part of the notes.
Sorry.
Okay.
I like to do that sometimes.
Yes.
Keeps it fresh.
Yes, absolutely.
Past this, thank you for this.
You're welcome.
But also thank you for having me on. You guys have been such like amazing support, and it's interesting because I tell my kids, don't talk to strangers, and like don't comment on things, and don't have relationships with like people you met online. But you literally started out as my internet friends. And then we've met, and like you're also great in real life. And nice. I'm just like thankful that we have a community, and I'm really thankful to be chatting with you guys.
Yeah, we have a really great community here in Southern California. We're really lucky. I mean, like how we were all able to get together in LA that one night it was awesome. I don't think I've ever been with that many trans women and trans men under one roof in my life. It was amazing. So yeah, we're gonna turn Southern California into this kind of like trans mecca and just beckon everybody to come party with us. So yes, absolutely.
You're probably gonna have to live in a smaller house, but it's worth it.
Yes, I'm sure. Why not? Yeah, that's fine. Absolutely. No problem, right? Everybody, come on out. We'll form a little enclave and everything. Yeah. Exactly. Yeah. Wait, let's get back to you.
Okay, fine. Yes. I
guess. Tell us about yourself, your family, your kids, all that good stuff.
Of course. So I was actually born here. I was born in Loma Linda.
Okay.
My dad was in the military in the Navy, which maybe we'll unpack that on a different episode. Right, and moved around a bunch. Lived in Europe. I lived in South America. I lived in Virginia. And came back here for college. Then did med school here at Loma Linda, where I was born.
Wow.
Did residency in emergency medicine in Chattanooga, Tennessee, which is actually like in and of itself is like a great spot. I mean, I know that there's some laws and stuff in Tennessee and the South that we're not excited about, but the town of Chattanooga I really loved. And then I did an ultrasound fellowship. That's like my area of expertise within emergency medicine. That's like my little focus in Kentucky, and then stayed. And I was the ultrasound director of all of the point of care ultrasound. So everything apart from radiology and OB. I was the director of like inpatient, outpatient, the med school, everything. And it was a lot of work. I really liked it. But then I was struggling a little bit. I forgot a very important thing right before med school. That was 15 years ago. I met my wife and we got married. And we've been together for 18 years now, married for 15, and we have 3 children. So I forgot that little important
tiny
thing.
Little bit,
tiny thing.
She won't mind.
And then back in it's probably 2020, I kind of got to this like breaking point where I knew that I wasn't safe for me to transition in Kentucky, where I was at. And I had a job that is transferable. And so I started looking for jobs and then moved down here in late 2021, which was the worst time to try to get a job, by the way. And then started transitioning essentially almost as soon as I arrived here.
Oh, wow. And that'll probably be something else we have to unpack on another episode, is this brain drain that's coming from the South now. I mean, like you had a job that was transferable, and because of like the laws, the attitudes down there, they lost a really great person who could have been serving the public down there. That's a perfect example of what these types of state policies do to a community like that, So, but again,
totally.
We're not doing politics, we're doing medicine on this podcast. So, and we did give a disclaimer before the break, but let's just say somebody came in after the break. Do you maybe want to give a little disclaimer? We're going to talk about a lot of medical stuff, but...
Absolutely. Yeah, so this is just things that are on the internet. This is not medical advice. I'm not your doctor. We are not forming a relationship, a medical relationship. I'm just letting you know what I know. And that's actually an important thing, is that I don't mean to say like anything that I say is not like the right way and not what I say the wrong way. That's not what that means at all. That just means that this is what I know, and this is what has worked for me and what I've seen in my experience. And it's definitely not a one size fits all. I mean, there's definitely transgender individuals out there that are on no medication, and that's fine. Right. So That's my very important disclaimer.
Excellent. And today we are also only going to be focusing on this topic of conversation on strictly adults. So just because your expertise isn't really in pediatrics and you transitioned as an adult, we all transitioned as an adult. We're just going to, so everything that we're kind of talking about today is for the over 18 crowd. So let's kind of, I guess, start at the basics, right? I mean, like for folks that are actually thinking about transitioning, really one of the first things that they kind of think about is perhaps either slowing or stopping their testosterone through the use of anti-androgens. And I know that there's, a few different choices out there for folks. I know that sometimes, an endocrinologist can kind of just shoehorn somebody into it based off of their personal experience, but maybe you could give us kind of like a little bit of a rundown on these different anti-androgens, maybe some pros, cons, side effects, like really kind of jump off that.
Sure. So I think the most basic one, which is where I started, was just taking finasteride, which is a medication that it was essentially produced to decrease the size of the prostate. And what it does, it just basically blocks DHT, which is the more active form of testosterone. So I started taking that at a low dose and kind of liked it. Then I increased the dose. I increased and went to a relatively high dose. And that one usually doesn't have any significant side effects. So it is one of the less effective ones, but the one that is less likely to cause any like big side effects. The main one really for finasteride is just it can affect your blood vessels a bit. And so it can make you sometimes more orthostatic, meaning if you go from sitting to standing quickly, you might get dizzy or more easily. So that's kind of like the big side effect they talk about. And that's basically it. And the benefits too is that, I mean, a lot of people actually take it for hair loss because it can help with that, because that's one of the main, DHT is one of the main things that causes male pattern hair loss. And then it also, helps with BPH, or benign prostatic hypertrophy, which is how, when I have patients in the emergency department, a lot of older men are like actually on this medication, lower doses than what we take, but on that medication. Do you want me to just keep going? Because I can literally blab on about this
absolutely.
for like hours.
Well, we've only got one though. We've got 1 hour, so we have to like.
Okay. So 1 hour, I'll blab on for 1 hour.
Exactly.
The upgraded version of finasteride is something called dutasteride, which is just way stronger. So you just take a lower dose, and it's got a much higher. The warnings of it are it can create breast growth. Which is that's why like a lot of us actually take it, is because it's stronger, blocks more testosterone. And typically what happens if you block testosterone, oftentimes your estrogen levels will actually go up a little bit, even if you're not taking estrogen.
Correct.
So those are kind of like the two kind of like lower risk ones.
Now, what about
good place to start?
Yeah, absolutely. Now, what about I'm going to totally botch this. The second one, the dutasteride. Is that how you pronounce it?
Dutasteride.
Yes. What about that one for hair loss as well too, or hair regrowth? Is that typically prescribed for something like that as well too?
Absolutely, yeah. They're essentially like related, same class of drugs. And there's actually I first heard about dutasteride when I think it was a study out of Korea that actually showed that after 3 months, like if you did nothing versus finasteride versus dutasteride, the dutasteride was way more effective than the finasteride. More side effects that we want, but not. Just more effective. So it definitely works with that as well.
Okay, so we've got those two class of drugs. And Liv, did you have a question? Did you want to jump in at all?
No, I'm interested to hear about some of the other ones. Yeah.
And then we've got those other two out there as well too. And I almost feel like people are kind of split 50-50 as to which one they either want to take or get prescribed. Tell us a little bit about those.
Sure. So I'll move down, and this is like kind of in order of like what trans people are usually prescribed here in the States. So the next one would be spironolactone, which I learned about it as a diuretic, specifically in the setting of like heart failure and liver disease. So what it does, it basically makes the kidneys shoot out more water, and the receptor it like affects also absorbs a little, or it it doesn't let you kick out as much potassium,
Mm.
but it kicks out sodium and water. So that's why it's typically prescribed. And when it's typically prescribed for those reasons, it's a low dose. It's like 25, 50 milligrams.
Mm-hmm.
But it also is a androgen blocker. And we trans people typically take it at a much higher dose than what's prescribed for its diuretic effects.
Mm-hmm.
So it's not uncommon for, if you're taking it as a transgender person, to take upwards of like 200 milligrams,
Okay.
which you don't start with that because, you know, I just mentioned that it messes with your potassium, right?
Mm-hmm.
So it actually, you start off with a low dose and you slowly increase.
Okay. And you had mentioned that it's a diuretic at low doses. Do we see that it becomes a even bigger diuretic when you get to those higher doses?
Theoretically, yes.
Okay.
And it's kind of like an interesting thing because one of the things that I haven't quite been able to like parse this out, I don't pee more than I'm happy to say what I'm on. I take 200 milligrams.
Okay.
I don't pee more. I pee more often, but it's like not
No.
necessarily more. So I wonder if it's one of those things where it works best when you are volume overloaded. And so if you're, you know, you're not using it for diuretic effects, like maybe it's not that big of a deal.
Yeah.
And the side effects, of course, that we worry about are shifts in the potassium. That's kind of like the big thing.
And what is the shift? Is it up or down?
It is up. It can actually cause hyperkalemia, which can mess with your heart muscles, which is kind of like a big deal. So you gotta be careful with that.
Your frequency of going to the bathroom was spot on. I think, you know, you definitely have to go more often, but it's less. Yeah.
Right. Yeah, exactly. Which is, it's kind of interesting because I'll be like, I have to pee so bad.
Yeah.
And in fact, when I was a resident, one of the things that I did was I wanted to see if I could, it's stupid, but please don't do this. I wanted to see like how much urine I could hold before I like had to go. And I was on shift. It was a really busy shift. And you know, I measured X amount of urine, and I kind of have experimented a little bit with that now. And it's like, a lot less, actually. It's like my bladder is like not, I don't know, swollen enough anymore to like maintain that like urine. I don't know what it is. Yeah.
Interesting.
Cool.
All right, and the last one would be bicalutamide.
Yes, and this is the one that I have kind of like the least experience with. It's generally prescribed kind of like almost like a puberty blocker, and it works by essentially making the receptors not be able to recognize testosterone, which all the other ones do, but this one does it more strongly. And it is actually, it's interesting. Like, I don't know if you guys have heard of Alicia Roth. I'm pretty sure. Yeah, I might be missing like a part of her last name. But she is a intersex woman who has something called androgen insensitivity syndrome. So it's basically like XY chromosomes, but didn't like develop fully as a woman. And that's because while there are testes and they do create testosterone, there's nothing to like read it. So to the body, there is no testosterone. Right. And so what this does, this medication, it basically like does that artificially. So that's why presumably, because again, I'm not can very much handle pediatric emergencies, but I'm not a pediatrician. That's why it typically see it in the kind of pre-pubertal and pubertal trans population rather than in the adult population.
Well, now I feel like a little kid.
You're a kid at heart.
Thank you. Yeah, I'm the odd girl out. I'm the one on the bike. But so we've got these anti-androgens. They either are stopping testosterone production or they're blocking testosterone at the receptor level. But not everybody even has to take anti-androgens. There's plenty of girls that are on that monotherapy as well too, and some that absolutely swear by it. So tell us a little bit about monotherapy and then how that also kind of plays into testosterone reduction and why some folks feel like they don't even need an anti-androgen.
Yeah. So, I mean, this is one of those things that it's why I'm very like clear that there is no one size fits all, right? Because and
Mhm.
that's medicine in general. That's actually one of the things that I guess I got stressed out about when I was
Mm.
like a medical student. And that was the fact that nothing is black and white, right?
Mhm.
Like absolutely nothing is black and white. Everything is shades of gray, and what works for one person might not work for someone who you think should work on it, might not work on that person.
Mhm.
And I remember when and this is actually something that I say all the time to empower patients, like even like just in the ER, like any patient, is that you can ask questions and you can say, ask about side effects, and you can say, I don't know if I want that, right?
Mhm.
One of the things with E is that, for instance, my endocrinologist, when I first started, actually like didn't really recommend any Spiro or progesterone, which
Mhm.
I love both of them. To me, they're important and they make
Mhm.
me, I like know when I haven't taken them.
Mhm.
But if you just take a lot of, I mean, not a lot, but if you take the appropriate amount of estrogen,
Mhm.
it does actually block testosterone to a certain degree. So to some people, that's all they need. I mean, the very first time that I took estrogen, I didn't take it at the max dose. I actually started at, I called it microdosing on E, is what I called it. So I would take actually a small dose without the Spiro. I was taking finasteride at the time.
Mhm.
Um, and I started seeing effects. And then
Mhm.
I liked it so much that I decided to go full and then take
Mhm.
the anti-androgens as well. But yeah, I mean, you can definitely just do estrogen monotherapy. I mean, that actually works for a lot of people.
Got it. Okay. Great.
Does
And
E automatically drop T levels?
Mm-hmm. Yeah,
Yeah.
it does. I mean,
Mhm.
it's not that estrogen like attaches to the exact same receptors all the time,
Mhm.
but it's just if you have a bunch of one, it almost like pushes the other ones kind of out of the way. It's more complex than that. But I'm also like I don't think that we want to know about how all the receptors and stuff work.
Yeah.
Really, like the main thing is just that it just if you have a kind of like a trans woman / cis woman level of estrogen, it should be enough to block testosterone to a certain degree. I mean, I imagine for people that are more, kind of non-binary trans femme, that might be enough.
Mhm.
But it doesn't block it to the degree that I want it blocked, which is
Yeah.
as close to zero as I can tolerate,
Yeah.
basically, the
Absolutely.
testosterone.
Mm.
Yeah.
all right, and that leads us
Great.
into kind of like, I don't know, I don't want to call it like a supplemental to like HRT, but sometimes it almost feels like it's treated that way. There's so many people that are like, I don't want any progesterone at all. There's some people, we were just talking about it before the show,
Mhm.
how all three of us feel that it's just so necessary in our personal treatment. So tell us a little bit about progesterone, how
Yeah.
that interacts, and like what part that plays in transition.
Of course.
Mm-hmm.
Progesterone, it's just like another receptor,
Mm-hmm.
and it increases basically the feminizing like effects of the estrogen. And actually, there's an anti-androgen that isn't, it's not FDA approved in the United States. It's cyproterone, and that is actually a progesterone derivative. So they all like basically block testosterone, and then potentiate the effects of estrogen. And there's a bunch of other, like, if you look at some of the biochemical data, there's actually other stuff that they do. Like, for instance, there's some effects on blood vessels. There's effect on cells. From a scientific medical perspective and from a personal perspective,
Yeah.
it's like the estrogen is like the picture, like the pretty picture, right?
Mm-hmm.
And then the to put a frame on it to be able to hang it up on the wall, like that final touch that you need, like that was the progesterone for me.
Mm-hmm.
And I started off
Yeah.
on a low dose and increased to the dose that I am on now, and I'm pretty happy with it. A couple of other like great side effects that hopefully it's okay if I talk about them, but
Yeah.
it's
Yeah.
I think we can.
it helps with sleep,
Yeah.
which that's something that I actually like I've struggled with even before I transitioned. I'm a horrible sleeper.
Mm-hmm.
I actually think it's a waste of time. I like hate sleeping, and so like I think my body, either I've convinced myself that it's bad because I can't sleep very well, or like my mind and my body are like the same.
Mm.
I wish that I could sleep the way that like a laptop charges, you know, like I know that
Oh,
I
yeah.
need charge, like I know that,
Sure.
but if I could plug into something and then also still do things while I'm recharging, like that would be ideal. Cause I
Right.
would like learn more languages. Like I speak like 2.5-ish right now. And I really want to learn more. Like I love languages, but I have to sleep at some point, you
I
know?
Could you imagine how much Instagramming I could do if I could also Instagram while I was sleeping? That'd be
Oh.
amazing. I could entertain people 24/7.
I would be more productive.
That's
as
our
well,
dream.
definitely.
That's our dream.
That's my dream. That's my dream, honestly. Like,
Yeah.
one of these days when you just listen, you just have to find me a vampire. Like
Deal,
I don't
yeah.
need to be out during the day. I
No.
don't like, I like the sun, but I'm okay without it.
Mhm.
Like,
Yeah.
but
We'll
preferably it's
talk
like
after the call. I know some people.
Yeah.
One of the
Okay.
one
thank
of the
you.
nice things I do like about the sleeping part of progesterone is that you it does relax you and you're able to sleep, but when you wake up you feel
Yeah.
great. It's not something that has
Totally.
it's not something that,
It's like
lingers
getting good
on.
sleep for
Yeah.
once. Yeah.
I walk on the wild
It's actually
side.
like the
I take mine in the morning.
what oh my gosh. Well, it is, and like it does actually, like I actually had somebody come into the ER, which is kind of funny because I have like this little bit of insight on these medications that like none of my other colleagues,
Right, of
as far
course,
as I
yeah,
know,
absolute
and
experience.
that's why I say like, yeah, that's what I say as far as I know, because like truly, like I don't
Of
know,
course.
like really anybody could be right trans,
Right.
but somebody came in and it was like everybody's like worried about it because this lady was like kind of altered and she was like, I got drugged or something. She was freaking out. And then I like went over a medication list and she had just started progesterone that night, like just started it. And then she was like, yeah, I took it. And then about an hour later, I got really like swimmy headed. And I was like, that's progesterone. That's actually what it does to you. So and then we discharged her. It was great. But yeah, it relaxes you on top of everything. So
absolutely,
yeah, like we've talked about it, Amber, how it's like
yes.
kind of,
I have a little
it's
bit
kind
of
of nice if you like,
I have a little bit of anxiety in the morning. You know, you've got that busy work day ahead of you and everything. You've got this crazy schedule. You got to get the kids up and everything. There's breakfast. There's so much stuff going on. And it's like, pop that progesterone and it's like you can feminize, you can relax, you can enjoy your morning. It's wonderful. Actually,
it has everything that you want.
So I have a question. This wasn't on our agenda at all or anything, but you kind of bring it up. So you were talking to this woman that was in the emergency room. I'm assuming she was not a transgender woman, correct?
Not as far as I know. I mean, I'm very focused on not asking questions that are not relevant to their care. Because it's actually one of the things that we hate, right?
Right,
like if
of
we come
course.
into the ER and we have a jammed finger, like no one needs to know if we've had bottom surgery. Like that's not important for the finger.
Of course. So
right?
she didn't self-identify and you didn't ask. But now with older women that take HRT for postmenopausal, would progesterone be part of that HRT that they're taking as well too?
Absolutely. Now, progesterone levels just as estrogen levels in a cis woman's cycle. Right? I'll say a patient a person that has ovaries cycle is it varies, right? And then there's I believe it's mid-cycle that progesterone like in people that have ovaries, the progesterone like peaks at mid-cycle and then kind of goes down. So it's a kind of one of these wavy lines. And yes, and it's one of the things for HRT as well. For postmenopausal women. And also it actually is a form of birth control as well. Like one of the more kind of popular ones is the little pellet that they put in the arms here. And those are basically like pure progesterone.
Okay.
So yeah, so I mean, this is why we even like know that it kind of like works is because we've seen people with ovaries that have it naturally and the effects that it has on them and side effects and all that stuff.
Okay,
now, one thing about the progesterone and honestly the estrogen that I have to mention, because it's one of the things that kind of like stressed me out the most. I'm an ER doctor. And so my training is what is the worst thing that can happen? Like if a patient comes in with shortness of breath, I'm thinking about a heart attack. I'm thinking about lung pathology, like a collapsed lung. I'm thinking about a dissection of the aorta, which is the big blood vessel that comes right off the heart. It's like the freeway of the blood. And then I'm also thinking about a pulmonary embolism or a blood clot to the lungs. And the way that they train us is if you're on estrogen, essentially, like they don't say this, but it's essentially what they say. If you're on estrogen, you will get a blood clot at some point, like somewhere. You're going to get one, right? It's super high risk, right? But before I started transitioning, because that was actually one of my fears, I looked at the actual primary data. And first off, the primary data is ridiculous. Like, it's just the reason why, like, to really like make, I guess, statements about data, you have to like understand statistics and like how data works. And to be clear, I don't like math. I hate it. But there are times it's useful. Now, there's a difference between an absolute risk increase and a relative risk increase. And the relative risk increase on postmenopausal women that were on estrogen, it did double the risk relative to the initial risk, right? So relative to the baseline. Now, the baseline risk on these patients, like if they weren't on estrogen, what was their risk of a blood clot? And it was, I forget the exact number, but it was less than 1%. And people who were on HRT, postmenopausal women who were on HRT, their risk went from less than 1% to slightly more than less than 1%. So it still didn't actually increase past a 1% risk, but it did double relative to the baseline. So that was an absolute risk increase, a relative risk increase. So it relative to the initial, it doubled the risk, which that's what all the headlines say, doubles your risk. But in fact, it brought you from less than 1% to slightly more than less than 1%. And that's with oral estrogen.
And that's not as sexy though. Like you can't be like
But
if you can produce a headline that says it doubles your risk, that's the sensationalism of it. And then of course we're also, there's obviously women that are, like women without ovaries that are in that postmenopausal range that this would be applicable to, but there are so many like transitioning people that are outside of that range. There had to have been more risk in a population that was only postmenopausal, correct?
Absolutely. I mean, that's brilliant insight, and you're totally right. I mean, listen, the body is only really meant to last a certain amount of time. And if you're kind of rough with it before, things break down and you're more likely to have these issues. That's definitely true. But I will say that a lot of the, so not the postmenopausal studies I'm talking about, we derived a bunch of like decision rules in emergency medicine. One of them is called PERC, or the Pulmonary Embolism Rule Out Criteria. And one of the criteria there are on, anybody over the age of 18 who is on oral estrogen. And it's one of the risk factors based off that. So it still is a potential risk, even if you're, 18 and perfectly healthy. It does increase the risk. It's very small. And I feel like, I don't know, again, just speaking for myself, like if I basically transitioned the latest that I could, and not like, I would not have survived, right? If I hadn't transitioned later than I could. So, it had to be done. And who knows, like maybe if I had taken it earlier, the data wouldn't be out. One of the more important things that helped me was the fact that if you look at the same data where they created the postmenopausal studies, if you take away those that were on transdermal estrogen, which trans is, other side, right? And then dermal is skin, so through the skin. If you take that, those patients out, the risk actually didn't increase at all. It wasn't statistically significant, but the risk was actually less than 1, meaning it was slightly more safe actually to be on transdermal estrogen than it was to not be on any estrogen at all. But it wasn't statistically significant. So I'm not implying that it's like healthier, I guess, in a sense, than not being on it per se. But injection, patches, and even sublingual don't appear to actually have any increased risk of blood clots.
Interesting. Well, thank you. Because I know it's such a misnomer in our community. It's the first thing that somebody that might try to convince you to not do this might bring up because of these older studies, because of the things that were tossed around in the past. So thank you so much for clearing that up. I know that another one too would be, there's also like cancer, increased cancer risk, I've heard is like, this horrible rumor that goes on about like, transitioning women. Tell us a little bit about like cancer risk or what you've seen on studies like that.
So it's actually, I was thinking about this here. I don't know if you guys have thought about this, but like, I just find it interesting that I'm going to be screened for like prostate, testicular, and breast cancer. like in a few years. Like I'm gonna actually need all 3 of those screenings, which is like, to me, it's fascinating as a scientist. The risk of prostate cancer, which is the highest, like the most common cancer overall in men, dramatically decreases.
Okay.
What you might see is that there's an increased risk of high-grade prostate cancers, which, by the way, the prostate gland in of itself, it does secrete a few things, but it's not really, that's not the focus of HRT, even though it is like an XY organ. It doesn't really have anything to do with, do you appear masculine or not, by the way. But that's actually also, you know, we're talking about, you have to like know how to read studies to be able to really like understand what the data means. And it technically does, there's a higher chance of you, if you're going to get diagnosed with a prostate cancer. So imagine like, this is the level up here of like your risk of prostate cancer, right? All prostate cancers, right? And then over here, we have the risk in trans women who are on, you know, finasteride and on testosterone blockers. If you happen to get cancer, which you have a super duper duper low risk of cancer, if you happen to get prostate cancer, it's usually a more aggressive type, which your overall risk dramatically goes down. And if you match this like small risk of the aggressive cancer with the group over here, it actually isn't an increased risk. It's just, if you happen to get diagnosed with prostate cancer, it's not going to be the common ones. It's going to be one that's a little like gnarlier, right? But it's not that you're going to get high risk or high malignancy rate of, or high grade prostate cancer because you're on HRT. That's not it. It's just, if you get diagnosed, it'll be a higher grade, but your risk goes down by like 100% essentially, right? So overall, it's not actually an increased risk, even a little bit.
You bring up a really good point, though, because I don't think that we talk about this a lot. I know that a lot of us talk about, oh, we've got to start getting mammograms now and everything as you develop breast tissue, and especially as we get older. But I have not heard a lot of talk about having to have a prostate exam and everything. So that is definitely something that trans women need to take care of and need to keep an eye out for, correct?
Yes, absolutely. And, you know, there's the whole PSA levels thing, which that's not something that I ever order. But I mean, getting that checked, I mean, everything is in conjunction with like your doctor and
of course
guidelines and stuff. But also, you know, you know, that's the other like thing going back to progesterone that I'm excited about is the sexual benefits with regards to libido that it helps with as well. But one of the more important screening tests for prostate cancer is actually someone examining the prostate, which is you know, finger in the bottom and making sure that the texture is average, and that it's not super firm or not super soft and not like bumpy and stuff. Like those are still important, even with getting PSA checks.
Got it. Okay. Cool. Okay. All right. Well, let's shift gears a little bit, because there is a whole nother population of trans folks out there, and that is trans men. And so we just kind of wanted to dive a little bit into that area as well, too. And I'm personally very unfamiliar with what trans men take. I mean, we're all familiar with what we experience ourselves. So maybe you could shed a little bit of light on that for us.
Sure. There are, you know, there's like good things and bad things. Like there's not good things and bad things. There's like things that we get excited about, and there's things that trans men get excited about, and vice versa, right? So usually, and it really depends on what they want to do, right? So for us, some of us don't want to be on testosterone blockers. We just get orchiectomies, and then we don't have to worry about testosterone blockers, right? And so some trans men, they just get hysterectomies. They get total hysterectomies, which removes the ovaries as well. And then they don't really need to take any estrogen blockers, which great. But if you don't want that, you can take androgen blockers. Androgens are, it's like the umbrella term for testosterone and estrogen, androgens. And you can take, there's blockers, like there's one of the more common ones is one called Leuprolide. And so you can take that and then testosterone. There's so many formulations of it, and I feel like this is like a kind of like a misogynistic thing as well, because there's so many different ways and there's so many different formulations and there's so many options for testosterone, but there's like essentially 2 for estrogen, which is funny. You know, you just have like the Valerate and the Cypionate for the estrogen. But irrespective of how you take the testosterone, it has essentially similar effects, right? And it's just whatever like works the best. And essentially, it's actually fascinating. Like if you look at in general, risk for cardiovascular disease in cis men is higher than cis women in general. Actually, in a lot of our risk calculations, apart from blood clots, like for heart attacks, for instance, right? You are at higher risk just if you're a male, like you automatically get like an extra point, right? And they found that after a few years, 5-ish years, the risk of trans man and a cis man are actually like identical, which I think is like amazing. Wow. To like think about it from a scientific perspective. So they basically run into the same issues that any cis male would run into in their 50s, 60s, 70s. The one thing that I think is important is that it doesn't actually increase testosterone, does not increase the risk of blood clots. It does increase the viscosity of the blood in some people, but that hasn't ever been translated into an actual blood clots. But it does increase the hemoglobin, which, when you hear athletes doping, sometimes it's extra testosterone so they can get more blood, which gives them more oxygen carrying capacity. So it's a normal effect. And one of the things that I'm a little like, I guess like jealous of in a very like, I'm very happy for you, but I wish I could also have this, is for us, like we need surgery or voice training to put our voices in a more feminine register. Whereas cis or trans men, all they need to do is take testosterone and their vocal cords will thicken. They'll have the voice just by taking
there's
testosterone.
wide ends,
So
and
I'm very happy for
ours
that.
doesn't do anything.
No, it's like done. Like you can't take it away. It's already there.
Let's get into that, I guess, a little bit then too. Like, I've been hearing, and I think I've even seen like a YouTube documentary. There's vocal cord surgeries now as well. Like, tell us a little bit about like that sounds a little bit extreme, very involved. Like, what do the results look like? And then compare that to like voice training, I guess.
Well, I mean, the main thing is that anytime that you have a surgery, I would almost assume that the outcome is not going to be exactly what you want. Like, because that is like easier to go into it that way than to like assume that you get the surgery and everything's going to be fixed, right? It's not really how surgery works, because anytime you saw surgery, you're causing trauma to the body. And the body's not always going to heal the way that you expect it to, right? So there's a couple of different ways. Now I guess the base example, like the core of what I'm going to say is basically think about like a guitar string. So on the top part of the fret, right, we have like the really juicy string, right? It's very thick. And that one is the lower one. So the thicker the cord is, the lower it's going to be. And the longer it is, that's another thing. The lower it's going to be. Now, it has to do with like the frequency, right? So the kind of surgeries are just trying to address that. Now the vocal cords are like very important because like they're how we communicate. And for me, the surgery is a little scary because my job is teaching and lecturing. And if I don't have a voice, like let's say worst case scenario happens, I don't have a voice anymore. Like I can't do my job. So it scares me for that. But there's a couple different ways that people do it. One of them is actually shaving down the vocal cords. So making them just thinner. There's a lot of issues with scarring with that though, because anytime that you have any trauma, you're going to scar, right? And imagine if you scar, it will thicken it, right? So it'll like, you might actually be worse off. Another one that's done that scares me as an ER doctor is there's a little area right here. It's called the cricothyroid membrane. And the cricoid cartilage is the lower one. And then I call it my madam's apple, by the way.
I like that.
My madam's apple is on top. And then there's a little membrane right here. And if there's a problem where somebody can't breathe and you can't get the breathing tube in their mouth, that's actually where you go in. You cut that to go in.
Okay.
A way that you can feminize a voice is actually sewing that closed, which stretches out the cords a bit, thins them out, and creates a slightly higher voice. So that's one of them. And then another one is the cords sit like this usually. Like this is, the front, and then this is the back. And so what they do, which is the one that makes the most sense to me, is they basically sew them here. So instead of it being out here, they actually sew them closed up here. So we still have an opening, but they're just essentially like this much shorter now. And that one's the one that makes the most sense to me. They either kind of laser them together or they sew them together.
Okay.
And those are basically the three kind of main options that we have. And they all have risks. And I, on Reddit, on the transgender surgery subreddit, that seems to be the one that people tend to not be as excited about the outcomes, right? And I even know one of my friends here had a surgery, and she didn't really do anything, and you go through a surgery and the outcome's zero. It can be very disappointing. So that one is the one that like I'm most hesitant about, and most of us, surprisingly, like we can, even though we don't think it. And I look at like my old videos because I have educational content online, and I still I hear that old voice, and I'm like I don't even recognize that voice as like me anymore. Like I don't remember that ever having been my voice. And I did it with voice training is how I'm able to kind of bring my voice to the lower end of the feminine register. It's with voice training and practice, just like anything else. So for me, I mean, it's definitely an option, and it would be amazing if I didn't have to think and I could just talk in the voice I have or I want. But the surgery to me right now is not worth it. But it is an option if you're okay with potential risks.
Got it. Okay. Yeah. Thank you for that. I don't think I've heard too much about that. So that was really, really great. I guess then that kind of does, we're going to stay, I think we're doing surgeries from like the neck up. I think we were going to talk a little bit about facial feminization surgery, but facial feminization surgery, it's not one like fit all type of surgery, right? It's like a collection of surgeries. Is that correct?
Yeah, it's kind of like an umbrella term. So it's just like a surgery to feminize your face. And it's not like you have to like check off these boxes for it to be considered FFS. It's just if you surgerized your face to look more feminine, you've had FFS, right?
Okay, yeah.
So I had my first one. It was a nose job. I'll send you guys a picture at some point. The forbidden like pictures. But I had a very Hispanic nose. I'm Venezuelan, by the way. I had a very Hispanic nose. And so what they do is they cut here, they bring the skin back, and they basically shave down this, which this is a bone and this is cartilage. So they shave a little bit the bone, they shave some of the cartilage down. And then if you happen to, and then they, sew it back. I have a little, next time we meet, I'll show you. I have a little scar right there where they did that. And then if your issue, because mine was it stuck forward too much, that was my problem with it. If yours is a little wide as well, they'll cut here, remove a bunch of tissue, and then sew it back. So instead of it kind of flaring out like this, it essentially gets pushed in like that. Okay. So there are two ways to do like a nose. I've had one trachea shave, which I'm hoping to get it a little further down. It's about 20% of what it was before. But they can go right here. With me, they went right at like the fold where my chin kind of meets my neck, because I wanted to be able to hide the scar a little bit better. And then the big one, which that's hopefully my next one, is forehead surgery. So it's basically a brow surgery, which that one is, it's interesting because I don't know how you guys, were before, but like for me, I never really thought like what makes a face feminine. Like I didn't really like think about it. For me, it was just like the nose was it, right? And then the Adam's apple. But there's so much more. There's chin, there's jaw, there's cheeks, which you can fix that with filler, which I'm very happy about. And then the big thing is the forehead. Like the prominent brow is a very like masculine look. So what they do is they'll cut here in the forehead. They'll bring the skin down. And then through different techniques, they'll basically shave the skull, from front to back, and then put the skin back and sew it. I mean, it's obviously I'm not a surgeon, and there's a lot more techniques than that, but that's the gist of it.
No, that sounds very involved. What kind of what kind of downtime, what kind of like recovery would a patient be looking at in a situation like that?
Yeah. So, the face one is the most intense, right? And you see
Yeah.
these pictures. I remember one of my kind of like trans kind of like mentors, even though she has no idea I exist, is that Gabby Offit, who used to be a WWE wrestler.
Oh yes,
So it was just like,
absolutely.
Oh,
Yes.
yeah.
And again,
yeah,
yeah.
it's just so inspiring because like she's was very very big, right? And
Yes.
then to like see how she was able to like do it, it was like
Mhm.
maybe I can do it because I'm not anywhere near that size, but I'm about
Right.
6 foot. I'm just under 6 foot. You know, I got big shoulders. I used to like working out a bunch. Um, but I saw that surgery and I was like, that's intense. But I'm gonna do it because it doesn't. I mean, it's what I need to inside be what's on the outside. You know.
Right.
I just had a nose, and I probably my downtime was a solid 3 to 4 weeks, and it was just a nose. They say that with the involved kind of forehead surgery, we need like a lot of reduction. That the downtime might be like actually 6 weeks, which is like a lot. So that's probably the worst recovery, not worst, the longest recovery is that. So definitely plan accordingly.
Yeah. Right. Absolutely.
Yeah.
Okay. So I've got a
Can
kind of
you?
another core. Oh, go ahead, Liv, please. Yeah.
Yeah, I just wanted to know. Can you go into kind of some of the risks of FFS?
Hmm?
That we kind of covered
Absolutely.
the
Yeah. So, yeah, thanks for that. So any surgery, there's risks, right? There's always risk of infection. There's risk of bad outcomes during the surgeries. They're low especially if you are like, relatively healthy beforehand. Which, to be honest, like I don't know a whole lot of surgeons that would do because this. I mean, to us, it's not elective, right? And this
Right.
is not elective to me. Like this is not like an option. This is like I have to do this or I wouldn't survive.
Right.
But it's something that like most of us that undergo this surgery, which to the medical community, unfortunately, it is mostly considered to surgeons. It's often an elective surgery. It's not like it's not like a bypass, right? That if they don't get the bypass, they'll die right now.
Right.
So if you look at the literature, there's really not that much actual like data showing risk, but any surgery there's risk. With the face, specifically the forehead, one of the more common ones is that, I mean, you think about it, like the nerves, you're gonna lose the nerves, right? Like they're going to like as they shave the skull, as they bring the skin down, it's very, I mean, it sounds gruesome. And I was actually talking to like one of my really good friends that I work with is an X-ray tech, and then the other one is an ER tech. And I was just like telling them like this. I was like, this is just it. And they see the same stuff I do, but they were really grossed out about it. So I want to acknowledge that it sounds like I'm a psychopath because I'm just like, yeah, you just peel the face off, but this is something that like I'm very comfortable with. Like I've been a physician for 11 years, 12 years. I've been a physician for 12 years now. So this stuff's like, so apologies if anybody like,
maybe we should do like, we'll do a graphic disclaimer.
A little
warning.
disclaimer.
Yeah, at the beginning.
We'll do a little disclaimer.
Yeah.
But you're bringing this down and you're going to sever the nerves. Like there's like a very low chance that you're not going to sever the nerves. So one of the big side effects is it takes a really long time for that sensation of the forehead. And you often, when they do the brow reduction, they'll often bring the hairline forward at the same time because they can actually do that with the same incision. It makes sense. But it sometimes takes up to a year to get back sensation to your face and your scalp. Almost everybody does, but that's kind of like the big, like, it's going to happen. Like, it's not it might happen. Like, you will lose sensation in your forehead. It's typically temporary. But that's kind of like the big one that for the face surgery, at least.
I do have one more question. Since we're on the topic of surgeries. So you're getting surgery done. HRT, specifically E, causes blood clotting. Is there a risk with that, or
no?
Yeah,
there isn't. I mean, that's actually I've had to, even now, like I had an appointment with a provider, a dermatologist, for a trans-related issue. And she was like, yeah, well, if you want to do this, then you'll have to be on estrogen. I was like, actually, like transdermal estrogen doesn't increase the risk at all. And she's like, oh, I didn't know that. Okay, you're good. So like and she was younger than me, by the way. So most physicians actually don't know this. But as long as you're on transdermal, there's no data in the cis woman or trans woman literature that shows that you're at increased risk for blood clots. That being said, the surgeons are in charge, right? So if the surgeon says get off of it, like, you know, like you have to understand that you have to follow those rules, and you have to be, because if you don't follow the rules, like a lot of us like wait a really long time for these surgeries, you know what I mean? And they'll cancel the surgery that morning. If they know, they'll cancel it that morning if you didn't follow, like, because they have their own level of risk tolerance, you know? And they, like I'm saying it, I would be comfortable operating on somebody, but I'm also not that surgeon who I never tell other people how to practice medicine, because they have to be comfortable with the way they practice medicine. So you're going to hear that. And the data doesn't show that, right? So it's about like having the conversation and saying, well, I thought transdermal estrogen didn't increase the risk. Progesterone also, that's another thing, going back to it. The progesterone, if you take oral progesterone and oral estrogen, it's 4 times increased risk of blood clots in general. It's still not a super high amount, but it does, like, they actually potentiate the potential, like a blood clotting kind of thing. But there's never been shown like an increased risk with transdermal and oral progesterone, transdermal E and oral progesterone. So it seems like you have to take oral essentially, and it has to do with how it's metabolized. The oral E is metabolized through the liver, and that's where your clotting enzymes are made as well. So if you're not using your liver to metabolize it, it doesn't affect clotting because it's after that.
Wait, doctor, I have a question then. That leads me to another question. The progesterone can be taken 2 ways. One way can avoid the liver, correct?
Yeah.
There is
another way.
Yes. Is it safer? There is another way. Is it safer to go the secondary route then, knowing what you just brought up?
So the secondary route is there is a transrectal formulation of the progesterone,
correct?
Which there's not enough data, or really any data, that shows a risk one way or the other. I really think that they're probably essentially equivalent. That's what I would assume.
Okay. But
really, like, the big thing is that if you can tolerate shots, I really the transdermal estrogen is by far the safest. And there's really not a whole lot of risk of blood clots as long as you're on transdermal. And then if you're on oral, like, you're still really low risk, right? You're still like less than 1% for most of the studies based off of the baseline population of cis women, right? Because cis women in general, they are at a higher risk for blood clots than age-adjusted cis men. So if you look at any other cis woman, you're not going to be at any increased risk with the transdermal, and then you're just a little bit more with the oral.
And then when just for clarification purposes, when you say transdermal, you're not just talking about transdermal patches, you're also talking about transdermal like applications, so also injections as well too, correct?
Yes.
Okay, great.
Yes. And actually sublingual also falls in that category.
Oh, okay, great. Okay.
So if you have like the one that dissolves under the tongue.
Absolutely. All right. Well, we're almost out of time, but I do want to ask you this question. So there's an old saying that there's no atheists in foxholes. And that means that, in a war zone, as a last resort, they're praying to their deity, in an emergency room situation where your doctor is trans, are there no bigots in the emergency room?
Yeah. I mean, I always I've thought this my whole life, doesn't matter what you do, there's 15% of people that are going to think you're doing it wrong. Right. And so in the emergency department, what I try to do as much as I can is I try to just be a nice person, irrespective of what people do to me, because no one comes to the ER for a well check, right? They're coming to the ER because most of them are having a horrible day. Right. And most of them are there because they want help. And I know that, I have a couple of other trans physician friends. And I know that my experience is definitely not universal. But I really haven't had that many negative experiences from patients. And part of it is maybe I'm in Southern California. I work in a quite red area of Southern California relative to California. But I've really had no issues. And I wonder if it's mostly because I very quick to redirect people. So it's almost like before the big thing was in Kentucky was my last name was very uncommon in Kentucky. And they would always try to go down that route of like, where's that last name from? And I would always, I can do the accent really well, by the way.
You do.
I would just redirect them. I would just say like, it's South American. So back to you. So I just always like, you identify those times where you think that they're going to like bring it up and then just quickly help them pivot. Cause it's like, no one's going to be happy about it. Like we're not going to have a biblical discussion as your arm is hanging off about, about us and how, your religion has nothing to do with me,
of course.
But yeah. And I have not really had a whole lot of negative experiences. I mean, I do, it happens a lot less now. And I believe that really the unlock was the voice, honestly, because I had a very deep voice before, a very masculine voice before. So the voice training has helped. But really like it took a solid, so my coworkers, they're all honestly, for the most part, dramatically supportive. It probably took a solid, I want to say a solid like year before I stopped getting misgendered. It might happen 1 or 2 times a shift. And I actually just correct them. I'm like, hey, I'm not mad, but it's she. And they're like, oh my gosh, I'm so sorry. And I'm like, it's cool. Just don't do it again. Just kidding. I don't threaten anybody. And then with patients, it happens sometimes. And honestly, with patients, I most frequently don't correct them because that would open up the door for the discussion. And it's kind of like a kind of like a risk benefit thing. And most of the time I just let it go. But I think I'm pretty feminine looking. So I don't think it like, it doesn't really happen all that much. But I will say that I have trans ER doctor friends who have had horrible experiences as well. So it definitely like still happens. And it generally is the intoxicated or under the influence patient or the demented patient is usually when it happens. So I'm a little more like lenient in those patients because there is if they're on something, there's a chemical altering their ability to make good decisions. Right. And then if they're demented, they're demented. They're, demented people can say some pretty horrible things and they don't know that it's happening. So how can I hold it against them?
Right. Well, I guess I want to close with this. Why did you come on the pod? Why did you agree when we asked you to come out here? What is kind of your advocacy? Why are you here today?
Well, I mean, probably the main reason was I hadn't seen you guys in a couple of weeks and I just wanted to see you guys again. But the kind of my thing, right? Like, cause I actually very much struggle, and thank you for that question. I've actually struggled with this because I see all of this, like all this misinformation. I see like, oh, the regret rates are X, when in fact they're not. And in fact, every other surgery, like literally every other surgery has a higher regret rate than the 1% of trans surgeries. So I have the data and the knowledge to interpret that data. So my kind of like the way that I want to be an advocate for us is through just education. I don't really have, I feel like I'm not the best person to discuss things like sports and like bathrooms, although I do have very strong opinions about those. What I am an expert in is medicine. And so when someone says, well, we can't do this because you're going to get a blood clot, you're going to get cancer. I can easily say, actually, no, like it actually doesn't increase your risk. Here's what the study that you're quoting actually says. I can show it to you because I'm trained to do this. It's my job to read studies and to stay up to date with medical literature. And so that's the kind of angle, maybe angle is the wrong word, but that is the avenue with which I advocate, is just through education to just explain that many of the people's biggest fears, and this is, eggs, closeted trans people, is like one group. And then also the people who think that their opinion on other people's bodies actually matters at all. And those two different populations, very different approaches. But that's kind of like, if you just show some data, there's going to be, that 15% of people that doesn't matter what you say, like they're done, like they don't care. They just want to not like you. But then I feel like there's a high chance that there's a significant population that might hear like what I say and be like, well, she's a physician. Like she's also trans. Like maybe she knows more than, a politician in rural Alabama that has never met a queer person person right?
God, I
So
hope they start
that
listening to
is
you.
kind of like my avenue.
Yeah.
Maybe, I don't know.
That'd be
I don't know.
great.
I'm not the only one. I mean, there's a med student that I really enjoy watching on Instagram, Dahlia. I'm not sure where she's at, but she's an intersex trans woman. And then I know that his Instagram is it's fairly soon. It's Transmed Proud, and it's a trans man. And he does a decent. He has a good presence and a good way of explaining things from the medical perspective of a trans man. Which is also like I'd recommend following both of them on Instagram.
There's all these tiny little pockets of trans people and trans communities all over Instagram. Like we have our little community, and then there's all these other ones. It's so awesome to see. Oh, I love it.
Yeah. And real quick before we sign off here, how can people follow you?
So I'm just kind of figuring myself out. I do have an Instagram. It's just my name is Jailyn.avi. It might be underscore. It's whichever one Instagram allows. And then if you happen to be interested in ultrasound and medical education, my website is at coreultrasound.com. But that's completely not trans related. That's just emergency medicine and ultrasound related. But yeah, I mean, Instagram is probably the best way to reach me.
We'll figure out. I've been told that we can like put your actual like Instagram like on a graphic below your name and everything. So we'll figure all that out. It'll look really nice. Yeah, absolutely.
Our production team will do that.
Yay!
Exactly.
He's upstairs.
Thank you so much for being on.
Oh, you're so welcome. Thank you for giving me this opportunity. I miss you.
I miss you too. I keep telling everybody we're gonna have you back for season 2, and then it's just gonna end up being like the same 12 people just coming on the episode over and over and over. But we do need to have you back for season 2. We do need to have you back.
Thank you. I mean, there's so much more to talk about, right?
There is. You can be our resident
like,
medical expert. That would be great. You can be
I
out of our
am
shell
ready.
medical expert. I love this.
Yeah, I'll put it on my resume.
Thank you. Absolutely. We'll add you to our LinkedIn company profile and everything.
Yay.
So. All right, Liv. Take us out of here.
Well, thank you, Jailyn, and we'll be back right after this.
Perfect.
Thanks.
Bye. Hi, it's Amber, your favorite podcast host. And don't worry, I won't tell Liv. Since we're still having a hard time finding actual sponsors for the pod, I wanted to talk to you again about our Trans Pride Apple Watch band for the Apple Watch. Last time, I touched on the fact that $10 from each sale goes directly towards the Trevor Project, and I'm happy to announce that the Out of Our Shell community has raised $3,000 so far. All of these dollars go towards the at-risk services that the Trevor Project provides. Some of these services include their at-risk crisis counselors that are available 24 hours a day, 7 days a week. And I wanted to give those resources today for our listeners. Not only can you go online directly to thetrevorproject.org, but you can also call them at 1-866-488-7386. And if you don't want to call them, or you might be in a situation where you might need privacy, you can even text them anonymously at 678-678. So if this is a project that you feel like you'd like to get behind, please go out and visit us at Etsy and find out more at outofourshell.etsy.com. And know that your dollars are going towards a good cause. Thank you so much. Let's get back to the pod. Okay, hi, and welcome back to Out of Our Shell, the podcast. We just wrapped up with Dr. Jailyn Avila, and that was such a great interview. Oh my God, I love that so much because it was just like, in that 1 hour, this was like essentially the crash course that you needed as a trans woman, to essentially understand anti-androgens, the different estrogen options, like clear up the misnomers. But for me personally, I mean, like, I really, really loved the fact that we went over the 4 different anti-androgens and, got to break them out into different classes of drugs and understand what they did a little bit more. So for me, that was kind of an area that was always kind of like cloudy for me. So that was kind of my biggest takeaway. What about you, Liv? What did you like about it?
Oh gosh, being new to the transition process, it was extremely informative to me for sure. There was a lot of stuff thrown out that I wasn't aware of. You hear the term blood clot a lot when starting HRT and especially estrogen.
Yeah.
And it just to hear about how it doubles, right? But it doesn't double to a dangerous
Right.
point. It
Yeah.
doubles from less than 1%. And so I thought that was really interesting. I like the insight on the FFS. Someone who's actually has a referral now. I found that interesting, the process, how they pull the skin back. And, it sounded maybe graphic to some. I found it interesting because that is the process, for us. And it is something that I think many women are looking into. And then, of course, it was interesting to me, and I think I asked the question about the blood clotting related to surgery. And so I was happy to hear that that's not really a risk. It's a possibility. It is still a risk there, but it wasn't what to me sounded like a high risk.
Yeah.
And then, of course, the watch fans.
The watch fans. Our watch fan club.
Story.
Absolutely.
Yeah.
Join the club, buy a watch band.
Exactly.
Yes.
Yeah.
Help Out of Our Shell grow.
Yes. And that's what I got out of it. Yeah.
That's awesome. That's awesome. Well, like we have done all through this podcast, this is a little reminder, especially for this specific episode, that nothing that we have talked about today should be construed as medical advice, nor are there any type of relationships that were built here on a medical basis whatsoever. This was more for informational and entertainment purposes only, and we're really, really glad that you were part of it with us. So with that, that's all the time that we have for today. I'd like to thank our guest, Dr. Jailyn Avila, for joining us on the pod this week. I also want everyone to know that you can find us on Instagram at Out of Our Shell, grab our merch on Etsy at Out of Our Shell, and tune into the podcast on YouTube, Spotify, and Apple Podcasts. And please help our little podcast grow by liking this episode and sharing it with a friend with that little share button. We really appreciate all of your support and everything that all of our friends provide to us. So on behalf of Liv and myself, we'd like to remind you all to follow your joy because it can never lead you in the wrong direction. Thanks for tuning in, and we'll talk to you next week on Out of Our Shell, the podcast. Bye.
Hey there, come out of your shell. Hey there, come out of your shell.
Don't forget to subscribe.